Lacey, thanks so much. We always talk about October is Breast Cancer Awareness Month, and in Oklahoma, a new way to remove breast cancer tumors, kind of some exciting technology that's just making its way in the state.
Oh, absolutely. It really is. And joining us to talk more about this new technology is Dr. Clint Merritt. You're with a surgeon at Hillcrest out of Tulsa.
Yes.
Thank you so much for being
Happy to be here.
Well, the first step, of course, is being diagnosed with breast cancer, but what comes after that and how does this technology help?
Sure. So usually the first step to a breast cancer diagnosis is getting your screening mammogram. We like to diagnose breast cancer very early. Why? Because we know the earlier it's diagnosed, the higher the survival rate's going to be. But if you are unfortunate and you do have an abnormal finding on a mammogram, the next step is usually a biopsy. And so a radiologist will call you back for usually a second mammogram and then a biopsy. If the biopsy confirms a breast cancer diagnosis, now we have to start talking about, is surgery indicated? And for patients who need breast cancer surgery, there's some new technology on the market that's really going to make that surgical experience as efficient as possible, and what we hope is as emotionally less taxing as possible.
We were just talking about just the anxiety of waiting on results, things like that. I mean, it can honestly drive you crazy if you're the one waiting or your family.
Oh, 1,000%.
What on the new technology is different than the prior technology? The prior technology was a little more invasive, right?
Yeah, absolutely. And so with new technology in the world of breast cancer surgery, how it used to partake or take place is once you had a biopsy and it confirmed a breast cancer, if you were a surgical candidate, what would have to happen is you would have to go into the radiology suite on the morning of surgery, usually several hours before your surgical time. The radiologist would then place the patient into a mammogram device and then using the mammogram device to guide a small wire or needle into the cancer. But the problem is that wire would have to stick out of the breast, usually several inches out of the breast, and the patient would then wheel in a bed from the radiology department over to the operating room where the surgeon would make an incision into the breast, follow that wire down to the cancer, and then cut out the cancer using the wire as the guidance.
All right.
And
so the new technology is with a marker and something called Molly.
Right.
You brought it. You're the first doctor in the state to use this technology. Show us how it works.
Right, so this is the Molly 2 device, and so which means the second iteration of the device. It's what we call wireless localization technology. And so it is a 3mm marker that's placed inside the area of breast cancer through a small needle, and then it's removed with the breast cancer at the time of surgery.
So there's a marker inside this implant, or what would be the breast, right?
Yep,
okay.
So this is simulating a breast here, and you can see the small 3mm marker here. And what you'll notice is we have this nice, we call it the Molly wand, and it's paired to a tablet, and this is the actual piece of device that we'll be using in the operating room.
Show us how it works. Let's take another shot of that. Here, hang on 1 second. We're getting, there you go, do it again.
So you kind of hear a futuristic noise here, and what it's telling me as the surgeon is when I'm getting closer to the area of breast cancer, and you'll see this green dot, and that tells me I'm in direct alignment with the breast cancer. And up top here, you see a millimeter distance marking that tells me how far from it I am. And so it allows me to not have only distance measurements, but directionality as well, allowing the surgery to be much more efficient the first time. And the biggest thing about breast cancer surgery is when we are taking out a cancer, you want the patient to feel whole afterwards. You want them to feel as good as possible about the cosmetic outcome as well.
Yes.
And so this allows me as the surgeon to be very accurate, very precise with the cancer excision, and then preserve that great cosmetic look afterwards, combining both good cancer resection but with great cosmetic results afterwards.
Well, thank you so much for sharing this and being the first to do this in the state of Oklahoma. Real quick, the guidelines on getting a mammogram. We don't have much time left.
Right. So what I tell patients is if you're an average risk patient, which means no family history of breast problems or cancers, you yourself have never had a breast problem, probably start mammograms at the age of 40. You want to get them yearly after the age of 40. If you are a dense-breasted patient and you've been told that you are dense-breasted, you probably need to be switching over to what we call a 3D mammogram and not the 2D mammogram.
Well, we talk about it every October. Dr. Clint, thank you so much for being in here. We appreciate you so much.
Thanks for having me.
We're back with more right after this. Keep it here. That's fascinating.
Yes.